What I want to talk to you about tonight is the surgical treatment of morbid obesity. So to define obesity and overweight, we use this terminology BMI, or body mass index. In those green folders you have, there's one of those is a table, a BMI table, and you can look up your height and weight and your body mass index. So that's how we define obesity by BMI. It's a ratio of one's weight in kilograms to one's height in meters squared. And so 25 BMI is considered overweight. Obesity is BMI 30 and higher. 35 and higher is moderate obesity. Morbid obesity is BMI 40 and higher. And supermorbid obesity is BMI more than 50. We follow the NIH Consensus Criteria for obesity surgery. That's the standard of care. And that's that morbid obesity is defined as a BMI more than 40 or 35 with at least one high-risk medical problem. We're talking about other medical issues like diabetes or sleep apnea or high blood pressure or fatty liver disease or any of those things. We like to see the patients also meet the following criteria to be considered for surgery: that they have failed the diet, that they are psychologically stable, that they have some knowledge about surgery and its potential outcomes and potential complications and risks, that they're motivated to be successful, and that they have medical problems that don't preclude them from likely survival from surgery. So before we start talking about the different operations, I think it's good to stop and define some of the terms you're going to see. So we have this terminology of success and failure from bariatric surgery. And so I think it's important to define what we're talking about. It's a bit on the harsh side, but we have to have a number where we can cut off success and failure. So we use that number as 50%. So people have to lose half of their excess weight after surgery, 2 or 3 years after surgery, to be considered statistically successful, okay? So this term excess weight loss, and we do it as a percentage of excess weight called percentage excess weight loss. Right? So what you do is you take one's actual weight minus the weight that we should be based on our sex, height, and frame, and that's one's excess weight. And the amount of weight one loses as they go on is the amount of percentage excess weight loss. So let's do a plain English, easy example. A woman of 5 feet who has a small wrist and is considered a small frame has an ideal body weight of 100 pounds. If that woman comes to the office and weighs 200 pounds in the office, the actual weight is 200, the ideal body weight is 100, so there's 100 pounds of what's called excess weight. A year after surgery, if that person has lost 90 pounds, they have lost 90 out of the 100 pounds of excess weight, or 90% excess weight loss. Everybody understand that? So it's not total body weight like they do in some of the television shows and things like that. So there are 4 major surgical treatments for morbid obesity. All the operations we do are laparoscopic, meaning minimally invasive surgeries. And they are adjustable gastric bands, sleeve gastrectomy, gastric bypass, and duodenal switch. So I want to work through those 4 surgeries with you. Let's start with adjustable gastric banding. This is one of the more popular surgery. There's certainly lots and lots of advertising by both the manufacturers of the lap adjustable bands in America. So people seem to be more inundated with information on adjustable banding than any other now in magazines and television and things like that. So this picture you see is actually a trademark picture of the quote-unquote lap band made by the Allergan company. So what you see here is this is the esophagus. This is the food tube that runs through our chest. This muscle structure here going across is the separation of the chest cavity and abdominal cavity. That's the diaphragm. And this is the esophagus as it comes through the diaphragm and joins into the stomach. So this band is put in the upper stomach, okay, right below where the esophagus and stomach meet. And the idea here is to create this small, we call virtual pouch, which theoretically will allow people to eat less, hold less food. The idea here being that this is what's called a pure restrictive surgery, in that the design of this surgery is just to create a smaller compartment, okay? And the success would be that the patient eats less because the stomach holds less, and less calories hopefully translates to weight loss, which hopefully translates to improvement in medical problems. So that's how the band is designed to work. This is our society statement from many years ago. This was our attempt at a new NIH consensus that was in DC in 2003. The paper was actually published in 2005. And the idea being that weight loss is about 50% in those who are successful at 2 years with a lap adjustable band with a mortality, risk to one's life at about 1 in 1,000. So we've already talked about how we do this. We put this silicone type band below the junction of the esophagus and stomach, and this virtual pouch is created and the surgery is restricted. So I like to think about things in terms of pluses and minuses in my life, in these major decisions, and I think the way we think about surgery should very much be the same. So we think about advantages and disadvantages of each of these surgeries. So the band is advantageous, and I think people come to the office with the idea of a band because they have a perception that it's simple to perform. It has the lowest mortality of any bariatric surgery at 0.1%, that's 1 per 1,000. The nice thing about the band and the sleeve, we're going to talk about the sleeve next, is that they maintain what I say is the continuity of the GI tract. What that means in plain English is that we're not creating any rearrangement or intestinal bypass. So the reason that that's pertinent is that if you don't disrupt the order or the continuity of the GI tract, you don't have to take vitamins and supplements for the rest of your life. Okay, so that's what that means, really. That's what the stressor is there. Bands are also attractive to people because they can be done either on a same-day basis or an overnight stay, and a lot of that is driven by the insurance companies. The band has a lower incidence of short-term serious complications. Those are things like bleeds and blood clots and leaks compared to the other surgeries. But there are several disadvantages. The first disadvantage is the statistical success and failure. Again, we're talking about the inability to lose half of one's excess weight. Okay? Does everybody understand that clearly now? So failure of weight loss, failing to lose half your excess weight, we tell patients in our practice that the failure rate is 60 to 75%. Okay, so it's a very high number. It's obviously more than 50% of the people, and that's in the US and worldwide. And I think a lot of that is driven by the fact that the band is a restrictive surgery. And we're going to hear a lot about metabolism and metabolic surgery in the coming slides. But the band is really the only surgery that doesn't change or influence metabolism directly. The sleeve, the gastric bypass, and the duodenal switch are all surgeries that change one's metabolism. And the reason that those things happen in the other surgeries is because there are important hormones that come from the gut and from the fat that we have internally. The band is just about making the stomach smaller. So it doesn't directly influence those very important hormones that have a lot to do with being overweight and medical problems that people have who are morbidly obese. Does everybody understand that? Okay. So I think that's the reason, the number one reason why people fail the band. Now the other concerning thing about adjustable gastric banding is the foreign body complications. And you see them all listed out here. I mean, the most important ones to mention are erosion, which is where the band can go through the wall of the stomach, problems with the esophagus, and problems swallowing over time. We tell people that the likelihood of a major foreign body complication requiring band removal is between 24 and 32% at 5 years. Okay? That means about 1 in 3 people who have a band are going to have it out within 5 years because of either a foreign body complication or a failure of weight loss. So, in summary, the band, it's a great idea in theory, I think. It's nice, it's not a stapling procedure, people have a perception it's an easy surgery to have. You can train surgeons, you should be able to train surgeons to do it fairly effectively and safely, but in theory, it doesn't really help the fundamental problem of obesity and the metabolic problems, and then there's a fair amount of harm, I think, that can come from it. Okay? So we've touched on pretty much most of these, which is the lack of an alteration of metabolism, and the fact that obesity is pretty much a metabolic disease. The only other thing worth mentioning is, I think body mass index also becomes a very important thing. It really becomes an important thing in talking about any surgery, but especially in BMI 50 and higher patients, there's a lot of data to suggest that if the band is somewhat effective, it's certainly significantly less effective in people who have a BMI over 50. And so, now the other thing is that people would say, well, you could do a band and you could do something else, right? Because the band's easy to do and we can take it out and do something else. The problem is that the foreign body nature means that this is a revision type situation. And revision procedures always carry more risk. So you want to try to make the best decision you can for yourself. And we try to help the patient make that decision, the first time around.